The design and use of checklists in safety or process-critical environments. Checklists can be really powerful tools in the search for safe or reliable practice. Checklists come in all shapes and sizes and serve several purposes, so great care must be taken in their design. This video applies to the formal, deliberate and orderly process that takes place in three specific situations. Situation 1, immediately before a safety or process critical activity. Situation 2, when an abnormality is detected. Situation 3, when an emergency is detected. Each type has its own form and function. An early question has to be, what is the problem for which this checklist is the support or solution? Problem definition matters because each type of checklist functions and is used in a different way. Three conditions require three categories of checklist: normal, non-normal, and emergency. The normal checklist is typically challenge and response. Its underlying assumption is that you know how to do your job. It is structured to support memory or coordination through a series of prompts. The prompt would normally be a single word and the response to it succinct. Any relevant activity is ordinarily completed beforehand. The checklist confirms that it has been completed. The checklist itself does not describe or take responsibility for any action. Making an appropriate response signifies acceptance of the responsibility for that item. The non-normal checklist is ordinarily read and do. This type of checklist is a how-to guide for when things cease to be normal. The goal is to restore normality or to control the trajectory of the abnormality. Its structure is based on the support of memory or cognitive capacity for ambiguous or infrequently experienced situations. The first step in its use is to establish clear and correct identification of the abnormality. Since the event is not an emergency, performing the correct activity slowly and deliberately is preferable to an immediate but inappropriate response. The emergency checklist is initially completed from memory. The situation is recognized as an emergency. There is an immediate need for action. The initial stabilizing activity is completed from memory according to an appropriate algorithm. Subsequent items in the checklist are designed to set up a sustainably safe condition and are performed as read and do as in the abnormal situation. Supporting expanded checklists would elaborate on team roles and what would need to have been carried out for a particular item to be considered complete or response to be given. The expanded checklist allows the team to understand the rationale and nuances of the checklist and provides a template against which compliance can be assessed. If the first question is what is the problem, the second question is the checklist fit for purpose? Is it designed for the real world? Users have to understand the relevant design criteria, the structure and best practice when using it. Users need to be sufficiently disciplined in their execution of the checklist. There needs to be an audit or review process which quality assures both content and execution. Sharing an understanding of the checklist formulation, providing education for checklist users, and maintenance of discipline in checklist use all have to be part of the package of checklist production. A healthcare example. The WHO Safe Surgery Checklist is probably the best known checklist in healthcare. Its purpose is to avoid harm arising from the clinical activity, iatrogenic harm, as opposed to harm from the patient's underlying disease or condition. The designers identified 10 safety critical items. There are 3 peaks of iatrogenic risk in any surgical procedure, so there are 3 separate checklists, each undertaken immediately prior to each peak. The first peak is when the patient is anaesthetised. The checklist is called Sign In. Major risks are patient identity, the need to breathe for a paralysed patient, an escape route if equipment fails, and the administration of drugs and allergens. The second peak in risk is when the skin is first broken. This checklist is called the timeout. Major risks are patient identity, correct surgical site, infection getting in, fluids escaping. The third peak is when the surgery is complete and the anaesthetic process can be reversed. This checklist is called the sign out. Major risks are something unintentionally left in the wound, are any samples removed, treated appropriately. Each of these risks can be tested by diligent and disciplined single-word challenges and single-word responses. Well-designed and properly used checklists can be really powerful tools in the search for safe or reliable practice.